that is in Kenya, but also regionally and globally. She's a palliative care physician and a public health specialist, and was the first director of Kenya Hospices and Palliative Care Association, in a position that she held for 14 years before she retired in 2021. Wouldn't say that, Zippy. But knowing her, yes, she's still very much actively involved in advocacy and creating awareness on pain relief and palliative care in Kenya for children and adults. And she serves on various boards in Kenya, the Hospice and the Palliative Care Association, as well as the African Palliative Care Association and the Alzheimer's Dementia Organization in Kenya. So it is absolutely my pleasure to say to Zippy, thank you very much for availing yourself to share with us palliative care in Africa. Thank you. Zippy, over to you.
Thank you very much. The introduction, Salome, and the Eco Africa Eco team, and also a thank you to the participants for joining today. I think I'll prefer to share my slides from my end, Charles, if that's okay. I'm already sharing them. Rose and I have been asked to talk about palliative care, the current status, the barriers and recommendations. My other colleague presenting today from Rwanda will probably focus a little bit more on Rwanda and how they have progressed. So mine is kind of to generalize what is happening in palliative care in Africa, and then a little bit of what's the developments that have happened in Kenya. I just thought I've written the objectives there, which you already received, so I will not focus on them again. I just thought for introduction, it's good to understand that we all know what palliative care is. I hope there's nobody it is really care that's given for people with a life-threatening illness from the time you make a diagnosis throughout the trajectory of the illness, in terms of supporting them with also extending this care to the family. But of course, the focus is to improve quality, to improve their day-to-day life by improving their quality of life. And maybe it's extended beyond cancer patients, oncology patients, especially in illnesses, but we also know patients with infections that also will benefit. Country to country, the level of palliative care is different, so it's not easy to generalize, but we'll try to see what the reports have been showing about development of palliative care. So some have well-established palliative care within their healthcare system. Some still have only, hospices exiting silos, and some have nothing at all in Africa. So again, there are a lot of potholes and a lot of need for advocacy, education, training, funding for us to be able to ensure that everybody in need of palliative care in Africa has access to palliative care, whether they're patients in oncology or patients with any other life-threatening disease, across all the ages, from children to adults to older persons as well. So some of the reports, one of the big reports that came out, the first report that came out for in terms of palliative care development in Africa, was by Michael Wright and David Clark, and this was attended the first regional palliative care conference that was hosted by African Palliative Care Association in the early inception of the association, and interviewed many of us who were there, and went from country to country interviewing, finding out what's happening in the countries in terms of service provision, in terms of education and training, in terms of access to essential medicines for palliative care, especially opioids, also looking at research and system integration of palliative care. So they came up with reports, and I'll just briefly look at some of the findings of this report. And then we've had many other reports that have come up by other researchers. I said I can't list all of them, but maybe just a few of them. Dr. Powell was the former Eve and other researchers looked also at palliative care development lessons from Uganda and Kenya. This is more recent in 20. One of the latest that has also been published is Progress palliative care development between 2017 and 2020 in 5 African palliative care sessions, Dr. Manuel Eureka. So the report by David and Michael highlighted that some challenges which were limited access to pain medication, inadequate healthcare infrastructure, cultural perceptions of death, lack of
Seems as if Zippy actually has now gone off. I think we do have a problem with the bandwidth there. Zippy, Zippy, I don't think Zippy hears me. You're on mute, Zippy. But can you put your camera off, because it's quite slurred, so maybe that would assist. But you're on mute. Charles, if you can, or Kenko, if you can come in there and assist and take her off mute, please.
She's back. Dr. Zippy, can you hear us?
I can hear you, but can you hear me?
Yes, now we can. Now.
Yeah, I'm sorry. There's all this blue thing that's going around on my screen. I just lost power. So let me see if I'll be able to get back.
Yes, maybe that's better. Just switch your camera off. Yes, thank you.
Switch it off
And
right
just with
now.
your slides. Thank you.
Yes, yeah. Let's share. So yeah, now you can hear me. I've switched my camera off, and I hope nothing else will happen. I'm actually now using my mobile phone to hotspot. These are some of the challenges that were identified during this report. Limited access to pain medication, inadequate healthcare infrastructure, cultural perceptions of death and dying, and then lack of trained healthcare professionals, particularly in rural areas. And like I said, some countries did not have almost nothing happening. Others had only hospices providing palliative care. I think in Kenya at that time, you only had hospices and a few mission hospitals providing palliative care. And so it differed from country to country. So the overall impression was that the services remained quite scattered in most African countries, and coverage was poor. Most of the palliative care was being provided by NGOs or mission hospitals. So the need for palliative care is great in our country, in our region, in Africa, yet we do not have enough access to palliative care for the patients because of the many reasons that I mentioned, but we'll also go into deep dive of some of these reasons. We know that, for example, pain medications are a big problem in this country, but in other African countries, we are told from the reports, the Global Atlas report says that 75% of the opioids needed are actually used of the opioids used are used by countries in North America or Australia or Europe, whereas where the need is highest in the low middle income countries like Africa regions, we have only maybe less than 10% or 1% of global opioids coming in to control cancer pain or any other pain for children and adults. So there is a big need. We know the number of cancer patients increasing And I don't want to repeat statistics. In Kenya, now almost 55,000 new cases of cancer. The latest I had last this week in some session that happening. So there's a big challenge. There's a big challenge in terms of access to palliative care.
Have we lost her again? Seems like it.
Yes, I think we've lost her.
Okay. It's going to be a bit of a problem. If everyone, so yeah, if just stay off camera. I wonder if we don't actually proceed, depending on, because I know last time she was on her phone. Shall we allow her a couple of minutes? If everybody can just stay off camera, please.
Oh. Okay, oh.
Maybe in the meantime, Charles has actually prepared for us a little questionnaire for those who are online. Maybe just while we are waiting to see if Zippy is able to join us again, can we actually project the questions, Charles? Right, so as Zippy indicated, palliative care is not available, I want to say, equitably in all African countries. So the question that we are asking everyone in this meeting is, does your country have a strategic framework for palliative care? So it's either yes or no or not sure. If you can please submit those questions. Has everybody been able to complete those questions?
Meeting, strategic framework, palliative care muna.
Hans, if you could just mute yourself, please. So the question is, does your country have a palliative care strategic framework? Yes, no, or not sure? As Zippy indicated, it's one of the problems that we have in Africa with regards to equitable access to palliative care. So if we can, so we've got 24 participants on this call. Is it possible to see the results already? Charles, can we see the results, please? Right, so the 75% of the people on this call actually indicate that yes, the countries do have palliative care strategic frameworks. There's a very definite 8% of countries that do not have, and then 17% that is not sure. Now, the one thing that we do not necessarily know is where everybody is situated on this call. So maybe I am going to ask everybody on this call, please type your name in and then say which country. Because it would be, although, yes, we will get the results also from the Echo platform, but it's actually quite interesting to just, you know, upfront, to actually see where everybody is from. Okay.
I apologize for what's going on. I don't know, the internet is bad, the electricity is gone off, the bundles are not working. I don't know what's going on.
Hello, Zippy. Welcome back.
Yeah.
In the
Yes,
meantime,
yes, I can hear you. I've requested that I just join with my phone and leave my laptop, and then Charles will share my slides.
okay. Thank
I
you.
think, yes,
In the
we were-
meantime, we've done is we have asked the question of how many countries, in terms of the people represented on this call, how many of people have got palliative care frameworks, and how many doesn't have.
okay.
So very interesting actually to come out there. There's 8% that indicated that they definitely don't have, and 17% that wasn't sure, but quite a high number of the people on the call actually indicated that they do have. And I actually have asked everybody on the call today that they just share where they are from, which country, so that we can just get a more or less an indication. Zippy, over to you. Back to you.
Okay, yeah, thank you. That's a good, because at least we can have a discussion later on what's going on in different countries. Can you hear me?
We can hear you. You're
Yeah,
audible.
so I'll just continue maybe and try to rush before anything else happens. Charles, I was on a slide on political development African, I think slide 6. Slide number 6. Yeah, so the next one after that, please. So yeah, so in the two countries, the Uganda and Kenya, we see there's quite a lot of development. They are both implemented strategies across all the 5 domains to develop palliative care usually. So in both countries, there's integration of palliative care into the national health system and also into the educational curriculum for medical and nursing. In Kenya, we have also included in the pharmacy training and allied professionals. Also, training of healthcare workers been supported by the American Cancer Society, also training of community health providers to be part of the palliative care fraternity. But apart from just this, we have short courses, again, in Uganda, Kenya, and other parts of the Africa, Rwanda, and the rest. But also we have diploma courses and degree courses in Makerere and South Africa. And then in Kenya, we have degree courses in oncology and palliative care in a number of our universities, mostly for clinical officers or nurses. So research is the one that needs to be developed in most of the countries. There's some ongoing research, but we need to focus more on research to be able to produce local evidence that will actually improve our patient outcomes. So the latest report by Dr. Emmanuel Eureka it shows also that there have been development of policies in a number of the African countries. Also, there's improved access to pain medication. So again, this particular report focuses on Rwanda and Kenya. Rose will talk about Rwanda, but I know in Kenya we now have a palliative care policy, as I'll mention later on, and also we are now developing a national palliative care strategy. We've developed palliative care guidelines, which are also under review, and also treatment guidelines. So in South Africa, I know they have gone much ahead than most of African countries, because it was one of the earlier countries that after Zimbabwe that actually started palliative care. Then Kenya was the third one. And they have many things that they've developed, and maybe Salome will share. Tanzania still has segmented palliative care, not truly as spread as it is in these other countries. So the key challenges are many. We still have a lot of challenges, despite the first hospice, which was in Zimbabwe, is almost 40 years old. But we still have a lot of challenges. In Kenya, we are now at 35 years old. We still have a lot of challenges. Uganda, I think, is like 32 years old. We're still having a lot of challenges. So some of the challenges, the key challenges are, for example, integration into the health system. It's not fully integrated into health system in most of the African countries. It's still isolated, where we have policies, where we have only hospices providing palliative care. So some countries, like I said, have national palliative care policies, and they might have the policies, but the implementation is still lagging in many ways, mostly because of health workforce, and also because of funding, and because of many other things. So the training and workforce is also not well distributed across Africa. Although we have these courses going on, they cost money. They also cost time, so we don't have everybody trained. So that is why the focus now is on training people when they're still in the medical, nursing, pharmacy, whatever education they're doing, medical, social work, that they get the basics of palliative care, so that at least they can provide palliative care wherever they are. And then, of course, the specialties are still, except apart from South Africa and Makerere, the other countries are now developing programs. Medications availability, again, this is different from different countries. In Kenya, we have Kenya and Uganda, we have a central production of oral morphine that is given to hospitals and hospices across the country. So this is a good improvement, but again, there is a lot of challenges, even in Kenya, as we talk about having access. Right now, as I speak, we have a shortage of oral morphine. This is a WhatsApp message where we wake up in the morning and see this kind of messages. Who has morphine? Where can you get morphine? Patients are crying. So we still, even though morphine and other opioids are on essential medicine list, we have a lot of challenges in terms of stockouts and patients being able to access these medications. So again, community-based initiatives. Again, in this report, it shows that most number of NGOs and CBOs in urban areas, but in rural areas, we do not have enough service providers. And again, because of many other challenges. So again, the key challenges are many, but again, the barriers, challenges and barriers are almost similar, but we find that among the barriers, we have policy and funding, the lack of government commitment to palliative care, insufficient funding, and the lack of palliative care policies is one of the things that have come out from all these reports. Although we have a palliative care policy in Kenya right now, we do not have a designated budget to palliative care. Our policy actually was facilitated through the National Cancer Control Program. So it actually, although it's under the National Cancer Control Program, it also includes other diseases as well. Of course, we have issues with culture. Although we have these services, most patients don't come because they think if they are coming to a palliative care center, to a hospice, they are going to be dying. So again, we need to be able to address these cultural attitudes and beliefs that are hindering people from accessing services, but also not just the people. I don't want to blame the patients, but even the healthcare professionals. We are not doing what we should be doing, referring patients early enough who are diagnosis of cancer to be able to receive the support that palliative care gives from the time of diagnosis throughout the illness of the trajectory. Having worked in a hospice for many years previously, our patients would actually be sent when they're very late, advanced stages, and you can still do a lot for them, but we would prefer that if oncologists can send patients early so that they have the benefits of palliative care. Of course, education and training, again, is a big challenge, a barrier. People are not trained well enough in palliative care. Funding is a problem, and now with what is happening with the funding reducing, we don't know what will be happening, but nobody really wants to put money into palliative care. The funders, the funders that we used to have most of them have closed up or are not funding anymore, so there's a big problem. What we need to do is really to encourage our governments to take palliative care as a responsibility of the government and fund services, fund education, fund medications, include palliative care into our national health packages wherever we are, because that's the only way you're going to be able to sustain palliative care services. Of course, like I said earlier on, lack of public awareness, but also policymakers don't understand what it is. When you go to the Ministry of Health and tell them about palliative care, all they think about is where are we going to get the money to introduce these new services. They don't realize these services can be integrated in what is already existing, which is what we did in Kenya. We did a lot of advocacy, and finally the government allowed us to work with the public hospitals to integrate palliative care. Of course, we had funding at that time. Now it's a challenge. So how can we address these barriers? And again, most of you I've not looked at the chart. I'll look at it later. Probably you have these barriers, and it will be good at the end to discuss how we think can address some of these barriers. So policy development is important. And again, this is from the latest report that Dr. Emmanuel and his team did. It talks about governments should develop and implement national palliative care policies that prioritize patient-centered approaches and allocate sufficient resources. But also one of the other things is increased funding for services, training, research, infrastructure, and workforce development, and education and training, that is establishing training programs for healthcare professionals in palliative care to enhance knowledge and skills, integrate palliative care education into the medical and nursing curriculum, and public awareness. Just addressing the challenges that we talked about above, we need to be able to address these challenges. And actually, when you do a lot of public awareness, it really helps. We did a lot of public awareness, a lot of media awareness, especially when we were lacking opioids in Kenya, and it helped a lot, even the policymakers, to start asking us, what are you talking about this thing? Why are you talking about morphine? And getting engaged with us to be able to ensure that people have access to the required medications. Again, of course, community-based approaches. You know that most of our palliative care patients usually are in the community. Even cancer patients, when they're receiving treatment, they don't necessarily have to be in the hospital. They go back home, so they need to be able to access these services at that level of care at home. Collaboration and partnership are important, and governments, non-profits, and others, civil societies, everybody really. We had a time when we talked about palliative care being everybody's business. It is everybody's business. So we need to bring in other partners as well to be able to address the issue. And then, of course, the biggest elephant in the room is usually access to medications. This is the challenge because of the psychotic and psychotropic the narcotic and psychotropic laws that were enacted some years ago, 1994, I think is the latest, have very strong language in terms of use of opioids. They talk about doctors who will prescribe and something happens, will be jailed, they will pay a lot of money. So reviewing the language in this act is very important, so that we are ensuring we have access to medications for people who need this pain medication, also access to medication for research, as at the same time ensuring that there's no trafficking or misuse of this medication. So the language we use also is very important, and training healthcare workers also to be able to adequately assess pain and appropriately prescribe, because again, one of the barriers is healthcare providers not prescribing. Next, please. So one of the things that the WHO resolution has really helped countries understand is how can we ensure palliative care for those in need in our own countries. This resolution was passed in 2014. Before it was passed, we had a side event in Geneva. And South Africa, Kenya, Uganda, some of the countries that actually supported this side event: Panama, Australia, and the US. And the result of this side event is that people actually, that room was full at that time. I remember, and people came and decided that we need to have a resolution, and WHO was very open to actually having a resolution for palliative care. So in 2014, there was a resolution. Last year, there was a meeting, and different countries had different levels of. Its title was strengthening of palliative care. So it calls country, if you can approach your WHO country offices to work with them, they also are usually very resourceful in trying to make us understand what the resolution is all about and how you can meet this resolution. So having policies we've talked about to integrate palliative care into the public healthcare system at all levels, but not just the public healthcare system. In Kenya, we have gone beyond public healthcare system. We have integrated into mission hospitals and private hospitals as well. The integration of palliative care into training curricula. Here in Kenya, we have put it into the undergraduate medical training curricula and the nursing curriculum. I think the nursing curriculum, the BSN has, I think, 35 units of palliative care, which is great. And then ensuring access to essential medication, including opioids, especially for cancer pain control. I think if we are clinicians here, we know that cancer pain can be very, very distressful for patients and also for the families. And this pain, when it's moderate to severe, will only respond to opioids. So it's also important that we have opioids in our country. Apart from just medication, products and technologies are very important, and supports to caregivers. Families and caregivers of cancer patients go through a lot, and they need to be supported. A lot of times as clinicians, we forget this part of supporting the caregivers. Quality improvement is important. We want to improve the best, and these are all from the resolution, by the way. We want to ensure that the services we are providing are good, and so we need to actually do a rain check and find out what our patients are saying about the services we are giving. And partnerships we managed to talk about before, and then of course funding for palliative care at the country government levels is very important. So our governments need to be very, very, very engaged in terms of funding for palliative care. So this diagram here is the public health approach to palliative care that tells us the things we need to look at. We need to look at drug availability. We need to look at education. We need to have a look at having policies, guidelines, and of course, implementation. Who are the people we need to influence for us to be able to implement palliative care in our countries? So these are just pictures of what happened in Kenya earlier on in 2007 to 2010, before palliative care was now being integrated into our public hospitals. We worked very, very closely with patients, their caregivers, and with media to bring out the issue of no access to pain medication. And so this really helped us as a country to even start working on a cancer bill. And I remember sitting in those meetings for the cancer bill and insisting that we must make sure that we're talking about palliative care education, we're talking about palliative care service provision, we're talking about access to pain medication for cancer patients. So again, advocacy is one of the things I want to tell you. And never give up, please continue doing advocacy, because it doesn't happen in a day. Get your patients, those living with this experience, their caregivers involved in advocacy. Identify a champion in the Ministry of Health, identify somebody who's empathetic, clinicians who are empathetic, and work with them to ensure that you're doing a lot of advocacy in your country. And the media actually is fantastic. It wasn't just print media. We had videos, we had TV media, we had all those things that we really tried to make sure that people are understanding why it's important for us to have palliative care in our country. So advocacy is important, and in Kenya, advocacy has resulted in a number of things. We now have opioids since 2013 among our essential medicine lists. We have a central manufacturing of opioids, morphine, that is manufactured. The morphine powder is brought in by the government. It's manufactured centrally and then sent to the peripherals. We started integrating palliative care into the public hospitals in 2010. We started with 10 hospitals, then seeing what the reports was coming from the hospitals, the government requested us to go back and work with another 33 hospitals. So right now we have we have 47 counties, almost all the 47 counties. I think about 44 have some level of palliative care. Some are at a higher level, but others also are trying their best. We have a patient's right charter in Kenya. 2013 that also says every person should have access to preventive, curative, rehabilitative, reproductive, and palliative care services. So these are the times, when you're developing patients' rights charters or developing a health law, you have to ensure that you're also not left behind in contributing to these kind of documents, because once you have them in those documents, you can always go back to your government and say, you say this is what you want to do. What are you doing about it? So now we have central manufacturing of opioids, but like I said, we still have challenges. We have stockouts because the government takes time to procure the medication and all the powder, and then it takes time to go to the center. Just a lot of stupid logistics that actually hinder patients from accessing medication. So the next slide, Charles. The next slide is just a slide that shows the letters that came from the government 2010 and 2012 asking us to integrate palliative care into the public hospitals. These were just letters that came as letters. They had no money attached to them. And it's because we did a lot of advocacy. So when the letters came, we couldn't say, no, we don't have money. We had to go back to our donors and show them the letters and say, we have these letters. We need to go to these hospitals. We need to train people. We need to help them set up palliative care units. And luckily, like I said, in those years, we had many people who were interested in supporting palliative care, the Open Society Foundations, the Diana Princess of Wales Memorial Fund, the True Colors African Palliative Care Association. All these people were willing to support palliative care. So we were lucky, for Kenya, we were lucky that we actually had very good funding to go and train. We're training like 20 people in each hospital, but not all of them were going to work in the unit, but sensitize the whole hospital. So that helped us a lot in Kenya. So these are some of the documents that have been developed in Kenya. Our latest National Cancer Control Strategy, Pillar 3 talks about treatment care and palliative care and survivorship, very well captured. And we have indicators that we are working on to ensure that we are on time, we are implementing what we had said we would do. By the way, the first National Cancer Control Program in this country, the only people who did something about it were the palliative care people. We are the only ones who actually did what we had said we would do. The rest had not, because we had funding. That we were lucky. But the rest of the strategy, nothing was done. But thank God, our government has now prioritized cancer care, and now we have a strategy. We have a National Cancer Control Program office. We have a National Cancer Institute office. So there's a lot going on in terms of assessing cancer care in Kenya. We have cancer treatment protocols that have also included palliative care and survivorship, and access to, and pain management treatment guidelines. One of the things that's also very important that we have in Kenya is the National Cancer Institute developed a document, National Guidelines for Establishment of Cancer Management Centers in Kenya. Now, this document has palliative care included in it. Ideally, you cannot set up a cancer center in this country unless you have the requirements that are in this book. So you have to be vetted by the National Cancer Institute. And some of the requirements include that you must have 2 nurses in palliative care. You should have a doctor, a palliative care trained doctor. You should have a social worker in palliative care. You should have, of course, the medication and commodities in palliative care. So this document also helps us understand that if you're a center that is providing cancer care, you have to make sure that you have everything that you need to be able to provide palliative care to patients. Of course, the cancer policy also talks about, has included palliative care. So ideally, a cancer treatment center should be focused on patient care, provide medical oncology, radiotherapy, surgery, and supportive services, provide psychosocial services and palliative care, including end-of-life care, provide patient-focused care, and care must be also multidisciplinary, because not one person can actually provide palliative care. A patient's needs are many. Like I said earlier on, they can be holistic, they can be physical, psychosocial, emotional, spiritual, and I always add financial for developing countries, because patients usually have to meet some of their costs out of their pocket, and that can be a very big challenge for them. Next slide, please. So this one just shows some of the policies that we have. The palliative care policy, you'll notice that we did a lot of things before a policy came on board. The policy, in fact, was the last thing to come on board in 2021. But we did a lot of things that made the government realize that palliative care is very important, and agreed that we can have a palliative care policy. This policy was spearheaded by the National Cancer Control Program and the Kenya Hospices and Palliative Care Association, but it cuts across other illnesses as well. So we want a Kenya population that is receiving palliative care throughout. We want people to live with good quality of life. The policy has got 7 pillars: advocacy and communication, leadership and governance, service delivery, availability of and access to essential medicines and commodities, human resource and education, health information systems and research, and healthcare financing. If you are familiar with this, the health systems, the building blocks of WHO, you will actually see that this is what guided us in developing these pillars. We had a WHO expert also helping us understand how we could use the building blocks to develop our pillars. Currently, we are actually developing national palliative care guidelines. They're being reviewed. So we actually had them since 2013, but now they're being reviewed to be updated. And then we are developing the first national palliative care strategy and first palliative care standards, which I'm hoping that maybe by mid this year they'll have been launched. We are working on them since last year. So the other good thing that has happened in Kenya is that we have a division in the Ministry of Health called Palliative Care and Aged Care. The picture is Dr. Esther Mwinga. I worked with Dr. Esther Mwinga when I was working with KEPCA. She was our coordinator for pain and palliative care and pain relief. She was actually seconded to us through the ministry. When we started working with the public hospitals, we went and asked the ministry to give us a doctor. It was not easy, but finally they gave us Dr. Esther Mwinga, who worked with us for a long time. When I say yes, I'm referring to the National Association because I was there for a long time. And recently, last year, she was recalled to the ministry and she's working in the ministry, the Department of Palliative Care and Aged Care. So this is all as a result of advocacy. And it was good to get somebody from the government to come and work with us and understand everything about palliative care. She's even now gone ahead and done a degree in palliative care at Makerere University, which I'm sure is going to support the work she's doing at the ministry level. So that's what I wanted to share. Thank you very much. Even as we talk, let us remember the foundation of palliative care from the founders, Cicely Saunders, who says you matter because you are, and you matter to the end of your life. We will do all we can, not only to help you die peacefully, but also to live until you die. So as much as we are developing policies, guidelines, training, our focus should be on patient-centered care, patient and family, that they feel comfortable, they don't suffer, they live a comfortable life. We might not, make it 100% comfortable, but do as much as we can so that our cancer patients are not living and dying with pain and suffering, that they can access these services. Thank you very much. And again, I apologize for the challenges I had earlier on. Thank you.
Thank you very much, Zippy, for that very comprehensive outlook in terms of what palliative care looks like across Africa, the challenges that we face, but also the deep dive into Kenya in terms of what your country, in fact, has achieved, and that is with dedicated work. And I know that you were, yes, very much behind all of that. Charles, while we allow Rose to prepare herself to join as the next presenter, can you also just put up the next sort of like question just for us? The next question is going to focus just on whether you actually have an pain control on your essential medicines list, yes or no. So it's just a short question there, or you don't know. So if I can introduce Rose. Rose Kahiri is a public health expert with over 38 years of experience working to improve access to quality and equity healthcare at a national and at a regional and international level. She holds a bachelor's degree in business administration and a master's degree in public health. And she has got a certificate in geriatric and gerontology. She is the founder and executive director for Palliative Care Association Rwanda. And she serves on many local, regional, and international boards and committees at a global level. She is also the co-chair of the Global Alliance for the Rights of Older People, which is a global alliance united in work to promote the rights of older people and advocates for the United Nations Convention on the Rights of Older People. So that question then, and if I can again ask everybody just to mute and also go off camera so that we can improve the bandwidth. So just a question before Rose starts her presentation. Does your country make provision for pain medication in your essential medicines list? Yes, no, or not sure? And if you can submit. Thank you, Rose. Over to you.
Yeah, good evening, good morning, everybody. Good afternoon. Thanks, Solom, for the introduction, and thanks, Dr. Zipa, who has done most of the work for me because she has done for Rwanda, for every country in Africa, mostly. What I'm going to say mostly like repeating what she has said, because I think the situation the same in most of African countries or sub-Saharan countries. But briefly, I talk about the journey. My presentation, Charles. So briefly, I will talk as Charles is putting up my presentation. Of course, Rwanda made some significant, the next presentation. Next, yeah, that one. Of course, I'm talking about the palliative care journey in Rwanda, and as Zipra gave us the whole of the palliative care in Africa, and I saw in most of her presentation there was also Rwanda. But the journey started in 2024, and that's when there was a peak of HIV and AIDS in most of African countries, and there were a lot of money coming in for HIV and AIDS that time. And, most of people were dying of pain, and you had what that time we were calling opportunistic infection, which I think today we are calling non-communicable diseases. And then we got a visit from African Palliative Care from Uganda, and then they started talking about, pain management and pain relief and survivorship. So in 2006, the African Palliative Care Association organized a training in Rwanda, and then they trained all the NGOs which were working on HIV and AIDS about palliative care, because they found that was a gap which was there. And then from there in 2008, we said, even if we've been trained on palliative care and how to manage, and we are working from different organizations, we should make up a palliative care association, as African Palliative Care Association advised us. And that's how the Palliative Care Association of Rwanda was born in 2008. So from there, as Dr. Zipla said, we started advocating how Rwanda could set up the structure of palliative care in the health system. And then in 2021, it was the first African country to launch a standalone national palliative care policy. And it had also palliative care guideline. It has palliative care strategic plan. And then in 2012, we also, the government put up the clinical pain management guideline, because at that time they have started, when we did advocacy about the pain relief and symptom relief, there was morphine, and that time morphine was being used for post-operatively, or it was using in the hospital. As most people know, that morphine that time was something they called dangerous drugs that time. So we did an advocacy, and then they set up a clinical pain management guideline so that doctors, nurses, and pharmacists could dispense morphine. And then from that time, when the policy was out, they started training of healthcare providers in tertiary, that's the district hospitals, and there was set what we call a desk for palliative care. At that time, there was also in the Ministry of Health someone who was in charge of palliative care. As Zipla said, that's good to have someone who is responsible for the palliative care in the Ministry of Health, because that person would be the focal point for every advocacy which was made. Unfortunately, today is not there. Then there is integration of palliative care at the district level. Even at the moment, the government has set a desk at the district level, which is called palliative care desk, and some nurses. Though we don't have proper trained nurses or doctors on palliative care, but you have that module of training for 5 days, nurses and doctors, and then they become the palliative care, not really qualified, but at least they have that knowledge into their work. So the government has trained at least every district hospital. We have about 42 district hospitals. There is the desk of a multidisciplinary team to know about and dispense palliative care. Next. So I said that the key achievement mostly was first, there was a stakeholders meeting. We called all the NGOs, and all the government called all the NGOs. Of course, I'm repeating what I said there. And then we came together, and then we drafted the policies, we drafted the strategic plan and implementation plan, which we have even today. Then there was a capacity building, as I have said, the training of palliative care to health professionals. Now we even have in the NCD policy, I will talk it later, the strategic plan and NCD, there is one part which trains the community health workers on palliative care. So they support, in Rwanda, we use more of community health workers at the community level. There is 3 to 4 people at the community level, which mostly deals with non-communicable disease, child and maternal health, and other infectious diseases. So there is someone at the community level, community health workers, who's trained in palliative care. But that's 2 to 3 days. It's not that they are more qualified because we don't have specialized palliative care healthcare professionals. Of course, there was even training some NGOs for them, especially those who are working on NCDs, to know about the palliative care in the organization. And if they get those cases, they know how to navigate the health system. Then there was again advocated for access to morphine. Morphine is given, when we advocated, morphine now is on the essential list of the medicine in our country. And then morphine, again, there's a liquid morphine production in Rwanda, and it is given from the district level, but then patients are allowed to take it, mostly the liquid one, to take to their homes. And then the pain is integrated now as the 5th vital signs, besides hypertension, diabetes, weight measurement, and everything. So it's now pain is covered and is reported in HMIS. And of course, to get this one, what I have said, Rwanda, we have what we call community health insurance coverage, which 94% of the population is covered by community health insurance. And this community health insurance pays for all the services, especially morphine. Liquid morphine is given free of charge without being paid. But then the community health insurance covers chemotherapy. We have some centers for chemotherapy, but community health insurance covers chemotherapy in one of the district hospital, which is the Butaro. And then it also covers radiotherapy in Rwanda Cancer Center. But of course, there is a lot of challenges also to that, which is in community health insurance, there is co-sharing, which government pays 90%, and then a patient pays 10%. But that 10% is still a big challenge to the patient or to the community, because, for example, if the session for radiotherapy is like 30, the cost of all the session may cost like $3,000, and the patient has to pay $300. Where would that, a person from the community or rural areas, where would that get that money to pay for the care sharing? So it has led to poor adherence to treatment, because most of the people can't afford the co-sharing. But the good thing is that of recent, the government has passed a guideline or a directive that all the medication concerning cancer, not all the NCDs, but cancer will be given without people paying co-sharing, which is really a very good step which our government has done. Then we look at care and support. Care and support, there is only one hospice in Rwanda, and which also is like a private. It is run by nuns. We don't have hospices in Rwanda. There is also patient navigation, which is done especially at the hospital level. But the issue is that the barriers is that there is no, after the patient gets out of the hospital, there is a problem. There is no community-based care at the community. And if it is there, it is just with a few NGOs which are doing it, I think one or two. And then patient navigation is still another challenge, which the government is looking, how can we do patient navigation, the system, navigating the system? Because in the end, patients are, there is a lost to follow, where the patient don't really know how to navigate the health system. Then there is an integration of PC in health system, and as I said, from the community to the district level, there is that integration. There is someone in charge of it, and then the community assurance, as I have said, the community workers, as I said. Next. Having said that, of course, as I was talking, there are a lot of barriers and challenges for people to access the PC, the palliative care services, and most of, I think Dr. Zipra has said, there is limited awareness in the general population. And this one, there is low demand about palliative care among the community, among health professionals. Some health professionals, they don't understand palliative care, what it stands for. They think palliative care is end-of-life care. There is low awareness among the policymakers, because there is also a culture of culture and mindset beliefs, which people think that when we talk about palliative care, end-of-life care. And then PC is a new type of treatment. Most people don't even understand it. And the government thinks that they think also it's the end-of-life care, and most of their priorities and money goes to infectious diseases or to cure, not palliative care. So the funding, there is also resource constraints of funding. Palliative care services are not really funded in Rwanda, especially when there is no money for research and palliative care. It is done by a few NGOs. There is conflicting policies, priorities among donors and governments. Of course, priorities is that they look at curative than palliative care, which they think is the end-of-life care that I continue. And then there is a lack of home-based care. As I said, when the patient gets out of the hospital, there is not any other services which is, takes that patient navigate the system. Then there is capacity building. There is a lack of education and training on palliative care. We just have in tertiary schools, because here nurses start in tertiary schools and universities, but they teach palliative care as just a small topic or a small chapter, but don't have a program or a curriculum in the university or nothing, or in the nursing curriculum. Of course, there is a lack of infrastructure, palliative care is done as a part of any other, disease in the hospital. There is no specific wards or specific department for palliative care in our health facilities. And there is no standalone palliative care services because it is all contained in the services. It is integrated into the health system. So that's another issue which we have. Next. So, as I said, there is inadequate. That's the challenges. There is limited accessibility and availability of pain management medication. Especially, there is also stock out usually, and some patients take some time without having it. There is inadequate capacity building, as I said before. There is lack of policy framework to support integration of palliative care into the existing health system. That one is not yet developed. There is lack of patient-centered and family-centered care because in our country, as I had said, they treat a disease, but they don't treat a person. So they look at the disease and not looking at a person. And as I said, the home-based care guidelines are not yet developed, and there is no guideline for it. So the recommendation is, as Dr. Zippler said, we need a lot of awareness on palliative care because most policymakers, most health professionals, most even the population itself, they don't understand the usefulness of palliative care. There is a lot to advocate for need for resource mobilization or location for palliative care services. I don't think there is any country which has allocated money for palliative care services in Africa, maybe South Africa, but as I saw in the reports, there is no country which has allocation for palliative care. There is a need for availability and accessibility of palliative care medication and care, which is very lacking, which we should continue advocating for. Need for palliative care policies enforcement. We can have such a good papers, we can have such a good policies, we can have, we can develop a lot of policies, a lot of guidelines, but the enforcement becomes, they are put in, the cupboard, and the enforcement and looking for funds for them, for those policies is lacking because the government don't have that awareness. Then capacity building, there is a need for capacity building on community, healthcare professionals and the community in general. And then there is a need for integration of palliative care into existing education curriculum. As I said, in Rwanda, it is lacking, and the need for infrastructure and facilities for palliative care in Rwanda. Next. So thanks very much, Visit Rwanda. As Dr. Zippler said, we should continue advocating for palliative care. It's lacking. We give a patient. We usually say that the patient is to be looked at in holistic manner, not a disease. A person is not a disease, but is a person, and that person should be looked at it or treated holistically and not looked at as a disease. Thanks very much.
Thank you very much, Rose, for that in-depth look at what Rwanda has done. And I think there's quite a couple of takeaway messages that we can take from Rwanda specifically. Thank you, Charles, for displaying the outcome of the poll of our previous question, and that is, does your country make provision for pain medication? So yes, 68 already makes provision for pain medication. And then in terms of the remainder, 21% is not sure and 11 is. And then I'm actually going to ask Charles, can you actually, before we go into the questions, Zippy, there is a question very dedicatedly wanting to ask you a question from Mishka. If you can just scroll up and have a look at that question. In the meanwhile, while Charles, I want to ask the question to everybody, is palliative care budgeted for by your government? Yes, no, or not sure? Because these are the kind of things that keeps on being the refrain when we start talking about equitable and affordable access to care for our patients. So if you can put that poll up as well for us in the meantime, Charles, and everybody can complete that poll. And I suppose the concept of budgeted for is actually also a debate. What does it mean, actually? So good. I'm actually just asking that same question to myself. Thank you. Then if Zippy, the question that Mishka is asking there, and I think it would also touch on what Rose has highlighted. What kind of challenges were faced with the actual implementation of integrating palliative care at a facility level? Was there a pushback from your clinicians and nurses? And how did you overcome that? If you can.
Thank you, Mishka, for asking that question. Yes, of course, we faced challenges. It wasn't all smooth going. First of all, most people are hearing about palliative care for the first time. And of course, the concept of palliative care is equal to end-of-life care was what we're really facing when we went there. And clinicians don't want to imagine that patients actually do get sick and die, which we know they do. But so one of the things we did, we had the challenge of people saying we have not been trained, we don't have opioids, we don't have enough staff, we don't have a room for palliative care. It was just, so what we did is actually, we knew we were going to face these challenges. What we did is we went to each hospital that we went to. We met with the management first, whether it was the head of the hospital and the management team. We sat in a room and had a meeting with them to explain what it is, what palliative care was, and how we were going to support them. So as they understood what it was and they understood how we are going to support them, and the fact that we went with support, we will train, we will help equip a room and all those things. Like I said, we had a lot of funding at that time. That kind of eased our way into it. So we had the first management meeting, but of course we knew the whole hospital needed to be convinced as well. So for each hospital, we requested they give us their time in the morning when they have the hospital CMEs, that we do a whole hospital CME where probably about 90% of healthcare workers in the hospital and even others that support also come to this CME as it's mandatory. And we talked in that CME about what palliative care is and how we want to support that hospital to do that. And then we went back, of course, now and trained people in each of those hospitals. And we trained from different departments, from the different whether it's obs, gynae, pediatrics, medicine, surgery, whatever, we brought them together and trained them, doctors, nurses, pharmacists, social workers, whoever was available that the hospital gave us to train. Mostly, of course, it was nurses, the bulk was nurses. And then the hospital decided, who are the two passionate people who wanted to be able to set the unit. And then we worked closely with these two people in terms of identifying a room in the hospital. Sometimes we didn't even get a room. At one place, we were given condemned public toilets that then were told turn that into a palliative care unit in Nyeri. We were able to get funding to turn these condemned public toilets into a palliative care unit within the hospital. And also in another one, we were given also another condemned building which didn't even have wiring for electricity, built, and then I don't know, maybe early 1900. But so we didn't give up. In whatever they gave us, we tried to make it work and support the people who are working there. We mentored them, we supported them, We visit regularly. We continue to give CMEs because once CME doesn't change people's attitudes, we continued. And we had also what we call the Pain-Free Hospital Initiative, where we trained clinicians in hospitals in different departments. There was a lot of effort and a lot of work that went into this. But then, of course, the clinicians were training. Quite a number of them were passionate about patients who were dying in pain and cancer. So this one's also helped a lot. They were part of the advocacy team in the institutions where they're working. So it wasn't just us, but even those who are working with the training were very engaging and dedicated. So I just want to say that the funding helped a lot. The fact that people believed that this was a necessary service, that the reports from the initial 10 hospitals that we worked with to the government, because every hospital has to report back to the Ministry of Health. The reports were coming in positively. We did a study immediately. We started these services looking at terminal ill cancer patients and the gaps in terms of service provision, and of course the gaps of pain management, psychosocial support. All these things came out, and we're able to use this document also as an advocacy document. So yes, there was resistance, but the training helped. The money helped. The money helped a lot, first of all. And I remember even in the government, before we started the integration, I was actually requested to go and talk to the heads of the department, the Ministry of Health. They usually had some monthly meetings, and through again a champion in the hospital ministry that I had worked with at the National Referral Hospital many years back, he actually was able to get me a slot to go and speak to the heads of the department and the Ministry of Health, and that also helped a lot because they didn't to understand what it was. So yes, but the resistance shouldn't let us give up. We just continue because people just need to understand where we are coming from. And sometimes if you have a patient who can go with you, the patient can also tell their story and their experience, and that of course will make them also understand there's a need for this. Thank you.
Thank you, Zippy. Rose, do you perhaps want to add anything from your side to that question?
Yeah, I think to add on what Dr. Zippy has said is you don't get tired of knocking at people's doors, especially the political, high-level political, for them to understand what is palliative care. But the challenge, as I said, even the clinicians themselves, they don't know what is palliative care. Like in our hospital, they think it's supportive care. So I usually tell them supportive care is a part of palliative care. So because when you tell them, let's develop palliative care for this hospital, they say, no, we have a supportive care in the hospital. Patient is put on oxygen. Patient is given pain relief morphine in the hospital. Then I usually tell them that that's not palliative care, because you are giving palliative care in the hospital, but palliative care is for both the patient and their families. So what happens to the family at home? Do you have that system also of assisting the families? So another challenge which I usually see in our hospitals is opiophobia. Some still have opiophobia, and even the government, they think you can misuse the opioids, especially morphine, and they still limit the doctors. Though the law of 2012 say that nurses and doctors and pharmacists and veterinarians can, in fact, prescribe morphine or opioids, but still it is, I don't know how it is, but nurses and pharmacists are not yet really given that power to prescribe morphine. So it is still with doctors. So there is still that push and back. But what I would say is, as Dr. Zipa said, is advocacy, and public awareness. Thank you.
Thank you kindly for that input there as well. And I'm going to actually, so Simon has asked the question, and that's directed, Zippy, to you, I would think. For capacity building purposes, is there any tertiary offering training on palliative care apart from Makerere and Nairobi? So anything else that you can share? And then I want to go back to Rose with a very specific question as well. Zippy?
Sorry, can you just repeat the question again?
So for capacity building purposes, so apart from Makerere and Nairobi, are there any other tertiary offerings, training offerings in Kenya?
Okay, in Kenya we don't have a university that is just giving a degree or a master's degree in palliative care as a palliative care by itself. Like I said, we have Moi teaching and Moi University that has a course for clinical officers, but they're also they're starting one soon. We've been working on a curriculum for the pediatricians and internal medicine doctors to do a fellowship in palliative care. It takes time to register some of these courses. AMREF has a course on oncology and palliative care. AMREF is African Medical, really, I don't remember exactly the whole word. Anyway, and we have the Kenya Medical Training College, which has we started a diploma, actually in 2013, we started a diploma at the Kenya Medical Training College, and we supported students for 4 years, paying their fees and everything. Then we handed over to the Kenya Medical Training College. So there's a higher diploma, but it's for nurses only. And so Mount Kenya University also has a training for clinical officers. So most of the training has focused on nurses and clinical officers. We don't have a specific one for doctors. It's something that is work in progress. But in South Africa, Cape Town has a good course, philosophy in palliative care, at a master's degree. And Makerere, like I said, has. For us, those of us in Kenya who did our masters, we did our masters and the diplomas actually in the UK, because at that time there was no training. So, but of course, this is costly. Some of us were lucky we had Commonwealth scholarships, so we were able to go through the Commonwealth scholarships. But we do need to, I think each country needs to build a team of trainers to be able to have local training, because it's a lot cheaper. The Nairobi Hospice has a higher diploma training in palliative care with together with Oxford Brookes University, but it's costly also for the students because they have to pay. It's a franchise of Oxford Brookes, so they have to pay money to Oxford Brookes. I think we need to engage our universities to start training palliative care in our own countries for our students that is affordable. And doesn't mean somebody has to travel. You know, you travel from work and that is costly. You have to pay for accommodation and everything else. So we need to engage our universities, our training colleges to have local training for our healthcare workers. Thank you.
Thank you, Zippy. And that brings me to the question that I particularly have then for Rose. Where you highlighted that one of the achievements that you have made in Rwanda is that training your community health workers. Now, I want to ask that question, is that a very dedicated training course for community health workers in palliative care? If yes, is that something that can be shared? And perhaps maybe that is also something that we need to look at in one of the other sessions that later on, in terms of how do we utilize community health workers and patient navigators, because I take away from what has happened in Rwanda the use of community health workers and patient navigators. Rose, if you can comment on that.
Yeah, thank you. In Rwanda, we have community health workers per village. And as I said, there are community health workers for mother to child, community workers for NCDs, community workers for immunization. So what I was saying is that in the NCD's curriculum for community workers, there is a big topic for palliative care, which we tried to insert in as association because it wasn't there. They were not understanding it. So what we were saying in NCDs, we inserted a topic on palliative care, and that one is a module from African Palliative Care Association module. There is a module for 3 days. There is a module for 5 days. So we took the one for 3 days because, you know, community health workers don't you can't take them 5 days. So we gave that package. It is like a basic palliative care training. It's not that they know all of it, but it is the basic palliative care knowledge which we give, because they take also other NCDs. But we said for them to understand well about the NCDs and how to care for all the patients who bring their NCDs to them, then they have to have that basic knowledge on palliative care and how they can support the people who come to them. So basically, it's not like that a new model, a big model which you can share, but it is integrated into NCD curriculum or modules of community health workers.
That sounds like something that we can absolutely learn from you. And I want to ask both of the speakers, because we've got experts here. I mean, with someone like Zippy, who has been in palliative care for all her life, you know, this is we need to utilize you as a resource. If you are willing, if you can share your details, you know, for some who want to actually email you. And I want to say, Rose, the same to you, if you are willing, because this is the type of thing that I really think that the ECHO platform needs to also enhance, is that we need to collaborate, and we need to be able to share best practice with each other. And that's the only way that we can do that, if we are willing to share best practice, and then start seeing if any of that. I have posted also, and I see also Mishka has posted on the chat there, in terms of the course that is available in Cape Town. Dr. Renee Kraus is actually the coordinator for the course here in Cape Town. And then she also has shared higher up some of the other institutions that have provided information there. So yes, so thank you, Zippy, and thank you, Rose, for sharing your details. Any other questions that anybody wants to ask? You welcome to put up your hand, or I'm not sure. Yes, put up your hand if you want to ask a question directly to any of the speakers, and unmute yourself, or post it in the chat. We still have a couple of minutes. Maybe while people are still perhaps thinking about particular questions, ask the question, and maybe that's again something, Charles, if you can, I know that's, and it's just something that I was thinking about whilst we're having the session. If you can put that up as a question, how many of the countries, do have dedicated palliative care for children? I mean, we know even that we don't even have enough palliative care in totality. And if I go back to how many countries or have actually got dedicated budgets, we've seen basically that a lot of countries, yes, it was 71%, have got strategic frameworks for palliative care. However, only 37% have actually got dedicated budgets. And that shows us what the work is that we have to do. So Charles, I don't know if you still have time to actually post that question there. How many countries do have very dedicated services for children? I can share that I do know that in South Africa, we do have a specific group of palliative care specialists that focus on palliative care for children. And it is actually quite amazing and stunning that such a service is also available for palliative care specialists. Don't know, Charles, if you're able to. I don't know if there's other countries. Zippy, maybe you can come in.
Sorry, is it about the budgets?
No, about children, specific
Yeah,
dedicated.
okay, yeah, that's a very tricky question. In Kenya, we don't have specifically pediatric palliative care. It has been a challenge for us. These services, actually, the ones we have are open to across all ages. But one of the challenges we've seen that is pediatricians don't really want to refer children. I think it's the issue of, or if I refer a child, I'm giving up on a child. We've had even sat in the Kenya Pediatric Association conferences, given, done side events at the conferences, talked at the conference, but we still see only 5% of the patients seen in Kenya are children, whereas we know the need is very high. So it's a challenge. Actually, it's a big challenge. But now we are working with St. Jude Hospital. They're trying. The St. Jude's team are trying to advocate for us to integrate palliative care in oncology, in oncology, in pediatric oncology. So it's a challenge, and I know it's a challenge across Africa. It's not just Kenya. There's a report that was done by UNICEF and ICPCN, that is International Children's Palliative Care Network, that again brought out all these challenges across Africa. Pediatric palliative care is very lacking, except maybe in South Africa is where they have the hospice for children. I can't remember the name. I visited some time back. You're the ones who actually have some dedicated palliative care or hospice care to children, but the rest of Africa doesn't have something really specific for children.
So
I think it is still a challenge. I mean, to all African countries. Even I think in Rwanda we don't have that dedicated infrastructure or focus on pediatric palliative care. But we have, they are treated in pediatric clinics or departments as the other patients. But in one of the hospitals in Butalo, they integrated it into oncology and in Siashka, but not specifically for, it's like a pediatric clinic or a pediatric department, but not specifically for palliative care. So as she was saying, we are starting to work with St. Jude. I was there last year to see how we can set up a pediatric palliative care in one of the hospitals, especially one in the center, which we call Siashka, which we are trying to develop pediatric palliative care. But otherwise, it's really a challenge, and I don't know how we shall do it, but we are trying.
And I think what we see then on the poll is that, yes, there's only 22 of the countries or people represented here percent that actually have got a focus for children. So yes, that actually, let us not forget the children. And it's great, yes, that St. Jude's is actually involved, because that's actually the way we need to go, is to work with St. Jude's to incorporate the children as well. I want to, from my side, I would like to say to both Rose and Zippy, thank you. Thank you very much for sharing your expertise and what happens in your countries as best practice, and that we can use in our countries, and also for your willingness to share your details, and for every single person that has actually participated with questions and also the poll. Thank you very much indeed. We're actually on time, and with that, I'm closing the session. Thank you, and have a good evening to everyone. Thank you.
Thank you.
Thank you all. Bye.
Bye.
Bye. Thank you.
Bye-bye.
Thank you.
Thank
Bye.
Thanks,
Bye.
Dinko.
Thank you. Bye.
Thank you. Bye.
Bye.
Bye, bye,
Bye-bye.
bye.
Bye bye.
Bye.
Thank you, Lori. Bye. Lori Buswell. Bye.
Bye-bye, everyone.
That was lovely. Bye.
Bye.
Thank
Thank you, Elvis.